So this is the second part of our antibiotic susceptibility lecture. We're going to discuss breakpoints, and a breakpoint is the highest concentration of the agent in the blood that can be achieved with maximal therapy. So if you think about when you take an antimicrobial agent, you ingest it, it's got to get into the bloodstream and get disseminated throughout your body so that it can work and fight the infection. Now, if you do an antimicrobial susceptibility test, and there might be an antimicrobial agent at a concentration that does inhibit the growth or kill an organism. However, if that concentration of the agent can never be achieved when you ingest that drug, then you wouldn't want to use that drug, even though the results show that there is a concentration that will inhibit or kill the organism. If you cannot get that concentration in your bloodstream, then a physician's going to look at the results and know, no, I don't want to use that antimicrobial agent because that concentration is too high to actually be achieved in the body. So if the minimum inhibitory concentration is less than or equal to the concentration of the drug that can be achieved in the patient's serum, then the organism is considered susceptible. If there is an MIC, so there is a dilution that inhibits the growth, but it's higher than the concentration of the drug that can be achieved in the blood, then even though there is an MIC, that organism is considered to be resistant because you cannot use that drug to treat an individual. And all of these numbers, the disc diffusion, intermediate susceptible, and resistant millimeter, the MICs from e-tests, the breakpoint numbers, they're all printed in the CLSI antimicrobial susceptibility booklets. And anytime these numbers change, clinical laboratories have to get a new booklet and have to follow the new numbers. And these change pretty regularly. So here's just an example of what some of the charts in the CLSI standardized booklets look like. So this one is an old table from Streptococcus pneumoniae with the microgram per mil MIC for various agents for strep pneumoniae. And you can see what would be considered susceptible, what would be considered intermediate, and what would be considered resistant. And these are the numbers you absolutely have to follow. Now, you can there's interpretive measures and tests that are done before these breakpoint numbers are printed. So even over time, for a specific organism, these breakpoint numbers might change. Over time, an organism might become more resistant. So these tests and analyses are being done all the time in order to make sure that these breakpoint numbers that are published are accurate so that every clinical lab is following the accurate numbers. Now, like any other test in the clinical laboratory, susceptibility testing has quality control. And how susceptibility testing is monitored in the clinical laboratory is with specific purchased quality control organisms. So you don't just take, oh, hey, we got a Staph aureus from a patient today. Let's go grab that Staph aureus and use it for our QC for our susceptibility testing. No, you have to use specific bacteria that are purchased from the ATCC, or the American Type Culture Collection. ATCC is a repository that has almost every single solitary organism and strain in existence, and you can purchase a specific strain. So for one test, you might need the E. coli ATCC strain 25675. I mean, there's specific numbers. And in the CLSI standard book, it will tell you exactly which organisms and which ATC strains you must use to do your quality control for that susceptibility test. So when you're first setting up a new susceptibility test, you would monitor this test every day for 30 days with your specific QC organisms. When you do make a new batch of media, you would do your quality control every week on your ATCC organisms. The common organisms for ATCC are E. coli, Pseudomonas aeruginosa, Staphylococcus aureus, Strep faecalis. There's several ATCC organisms that are required for each susceptibility test. Now, I already mentioned that normally our disc tests are done on Mueller-Hinton-Auger plates, whether it's an E test or a Kirby-Bauer test or your typical disc diffusion test. However, for our fastidious organisms, those organisms may not grow up on the general Mueller-Hinton-Auger. So modifications have been developed, and these are all printed out in the CLSI standard books as well, and you really have to follow exactly what they say. So for Haemophilus influenza, remember, one of our fastidious organisms, you have to use a specific media called Haemophilus test media for susceptibility testing. This is a Mueller-Hinton-Auger that contains some extra goodies in it. It contains nalidixic acid, it contains hematin, yeast extract, it contains a lot of different things in it that Haemophilus needs. You also are going to incubate this in the CO2 incubator. For Streptococcus pneumoniae, you use Mueller-Hinton with sheep blood. Your strep organisms like a blood source to grow. Again, you're going to incubate in a CO2 incubator. Neisseria gonorrhea, you would do your susceptibility tests on chocolate agar, and again, you're going to incubate it in the CO2 incubator. For Staphylococcus aureus, to test for methicillin resistant. Remember, we already talked about this. Methicillin resistance in Staphylococcus aureus is due to the MEK-A gene, which alters the site where methicillin, the antimicrobial agent methicillin, that synthetic penicillin, is going to bind to your bacteria. So keep in mind that methicillin-resistant Staphylococcus aureus is not really more virulent. It's Staphylococcus aureus. It causes the same infections as methicillin-susceptible Staphylococcus aureus, or MSSA. It's just more difficult to treat, and more people will die from these infections because they're very difficult to treat. So remember that people are colonized with Staphylococcus aureus in their groin, in their nasal passages, under their armpits, in these darker, moister areas. You can also be colonized with a methicillin-resistant Staphylococcus aureus just as easily as a methicillin-susceptible staph, and you don't get any disease. It's when a healthcare worker is working directly with patients and then infects a patient with their own normal MRSA that they're carrying, and then that sick person gets a MRSA infection that's very difficult to treat. So this is an old pie chart, but it hasn't changed all that much. The majority of the MRSA infections that you are going to see and you're going to isolate MRSA from in the clinical laboratory are wound specimens. You're going to get Staph aureus a lot from urines, from blood infections, from sputum, surgical sites, but the majority will be from wound specimens. To detect methicillin-resistant Staphylococcus aureus to do your susceptibility tests, you want to use a specific media, and that is Mueller-Hinton agar that contains 2 to 4% sodium chloride. You're going to incubate those plates at 35 degrees for 24 hours. Most of our susceptibility tests are done overnight, which is usually around an 18-hour incubation. For MRSA, you really want to make sure it's a full 24-hour incubation. There's a very easy way to look for MRSA. They make these oxacillin screen plates. They are agar plates that contain oxacillin in them. A lot of times these are little biplates. One half is agar without oxacillin and the other half is agar with oxacillin. You could take your Staph aureus, streak it on each side of the plate. If it grows on both sides of the plate, it means it's resistant. It didn't get killed by the oxacillin. If it grows only on the side without oxacillin, then it would be considered susceptible. It's getting killed by the oxacillin. The organism won't grow on it. There are also little oxacillin discs, little paper or typical discs, and you really have to examine the zone of inhibition using an oxacillin disc very thoroughly. So the oxacillin discs make a haze around the disc, and so you actually have to measure through the haze. So what will happen is there'll be a very clear zone, then a slight haze of a zone, and then your full growth. So you want to go end to end through the haze. Now, methicillin-resistant staph normally are not going to respond to beta-lactam antibiotics. So, your cephalosporin antibiotics are automatically reported resistant if you have a Staphylococcus aureus that's resistant to oxacillin. That's very important. So you're going to put your organisms in your Vitek or in your microscan, and it's going to give you a bunch of different reactions or susceptibilities. Regardless of what the instrument says, you're going to cross out any result of a cephalosporin and put resistant, because there might be a cephalosporin that shows up that it would work. The organism is susceptible to it, but you don't want to use any beta-lactam to treat it. So you wouldn't want to report this to a clinician because they might treat using that drug when in fact none of these beta-lactams should be used. So usually in the area where you're screening the results from the susceptibilities from your instrument, there's going to be little notes in your lab, automatically report resistant for XYZ, or automatically do this test if you see this result. A lot of labs put up these little cheat sheets, which is very important because when you're standing there and looking over all these results, you want to be able to easily say, okay, this, cross out, make them resistant. So, most labs will make it, a little easier, but it's still good for you to remember some of these things. Now, there are problems with using oxacillin. So I already said that there's this hazy zone that you get with oxacillin discs. So it's very difficult to read the tests accurately, either from broth with oxacillin in it or from your plates. So usually the MRSA testing, you have to do what's called an induced susceptibility test. So instead of using oxacillin discs, nowadays you don't use that. You use a 30 microgram cefoxitin disc instead of a 1 microgram oxacillin disc. If cefoxitin resistance is observed, you change the interpretation to resistant, regardless of what the MIC shows for penicillins, cephams, aztreonam, any beta-lactam antibiotic and beta-lactam with a beta-lactam beta-lactamase inhibitor combo, as well as all of your carbapenems. So this is where it's very important for you to interpret. The machine isn't going to automatically mark all of these antibiotics resistant if the cefoxitin is resistant. You've got to look at the cefoxitin, see that it's resistant, and then manually report out that it's resistant to all of these other antimicrobial agents. So you can do your Staphylococcus susceptibility using microdilutions. You could do them for agar dilutions. There's e-tests for MRSA, your disc diffusions. So there's many different methods that you can use to identify MRSA. Now, for things like other antimicrobial agents like vancomycin or gentamicin that the staff might be intermediately susceptible to, there may be specific methods that you'd want to use. You probably wouldn't want to use a disc diffusion method. Now, there's something called the D-test that clinical labs will do. A lot of clinical labs will do this test, which what the D-test does is it confirms a test for an erythromycin-resistant, clindamycin-susceptible Staphylococcus aureus. So when you guys are looking at your susceptibility results for a Staphylococcus aureus isolate, when you see that it is resistant to cefoxitin, you automatically make it resistant to all of the drugs that we listed on the previous slide. But if you also see that this particular Staph aureus strain is resistant to erythromycin, but it's susceptible to clindamycin, you then need to perform a D-test. And what the D-test is you will drop a clindamycin disc next to an erythromycin disc, and your zone of inhibition will become the shape of a D. So if that happens, it's a positive D test, and it actually needs to be reported as clindamycin resistant. Even though the machine called it clindamycin susceptible, it's really clindamycin resistant. So here's an example of your D test, where you have your discs that they technically need to be a very specific distance apart. You don't want them right close to one another, where they'd be able to each have their correct zone. So the right hand side is D-test negative. You've got your circular zone of inhibition, no blunting. But the plate on the left shows a D-test positive. So you have the blunting around the clindamycin disc in between the erythromycin disc, and it looks like the letter D. So in that case, even though the machine called it clindamycin susceptible, you change it to clindamycin resistant. That's what you report out. So if the D-test is negative, you get a circular zone around the clindamycin disc, it's clindamycin susceptible. If the D-test is positive, you get that blunting, you report as clindamycin resistant. So even though for that strain, clindamycin may in fact be an effective antimicrobial agent, but you don't want to treat this strain with clindamycin because you're just going to develop clindamycin resistance. So now we're going to talk about another organism, our Vancomycin-resistant Enterococcus. So our Enterococcus organisms inhabit our gastrointestinal tract and mucous membranes. They're able to survive in 6.5% sodium chloride. The vancomycin resistance is due to the VAN genes, VAN A, VAN B. It was first reported in 1986, And the risk factors for getting a vancomycin-resistant enterococcus infection are usually individuals with underlying disease and individuals that are in the intensive care unit of a hospital. So usually more sick individuals. So vancomycin resistance came out from overuse of the antibiotic vancomycin, people not taking their antibiotics for the appropriate durations of time, people that have preoperative bowel preparations because they might be taking antibiotics for the surgeries and things like that, as well as overuse of third-generation cephalosporins. Now, just like Staphylococcus aureus, many people can asymptomatically carry Enterococcus, including vancomycin-resistant Enterococcus. It can be detected in the stools of colonized hosts, and vancomycin-resistant Enterococcus causes a variety of infections like urinary tract infections, surgical site infections. It can cause a bacteremia or blood infection. And the problem with infections with VRE, although they cause the same infections, the mortality is twice that of vancomycin susceptible Enterococcus. And that's because it's very difficult to treat a vancomycin resistant Enterococcus infection. And also the people that get infected with VRE tend to be much more ill individuals in the first place. So for prevention and control, you want to isolate your infected patients that are infected with these highly resistant strains. Healthcare workers need to use barrier precautions when working with these individuals. Proper hand hygiene, changing gloves in between patients, washing your hands all the time, using dedicated equipment on these patients and making sure it's sterilized before it's used on any other patients, using appropriate antibiotic management, and restrict the use of vancomycin unless it's absolutely necessary. We're now going to move on to the third part of the lecture.